These two are my abstracts. The first one is capivasertib, which was discussed in SCBS 2022. So we all know alpelisib, which is not so tolerated by most of the patients because of the hyperglycemia, fatigue, and rash and everything. So other drug in the armamentarium for sequencing with the PA3KC mutation analysis are, if not also, is capivasertib. So capivasertib, what is the background of usage of capivasertib? We all know AKT pathway activation occurs in the HR positive advanced breast cancer, the PA3K, AKT and PTEN. This is a sequence. So capivasertib is the one which act on the AKT, the down sequencing pathway of the PA3K. So introduction of capivasertib, is it going to make any difference in HR positive advanced breast cancer is the discussion. So capivasertib is a potent selective inhibitor of all the three AKT isoforms. It already established its efficacy in FACTION trial. The addition of capivasertib to fulvestrant significantly improved PFS and OS in postmenopausal women with AA-resistant HR-positive advanced breast cancer in the overall population with a more pronounced benefit in pathway-altered tumors. It's already got established in the phase 2 trial, the FACTION trial. So what is a CAPItello study? What's the overview of this study which got published in the NEJM article? So it's a phase 3 randomized double-blind study. Here the patients are again, it's a HR positive, HER2 negative advanced breast cancer. There is less than 1 line of chemotherapy got received and less than or equal to 2 lines of prior endocrine therapy got received in the advanced breast cancer. The recurrence or progression while on or less than 12 months from end of adjuvant AS got included, or progression while on prior AI for advanced breast cancer. So prior CDK4/6 inhibitors are allowed, at least 51% are required to receive CDK4/6 inhibitors. Later, I will dissect the subgroup like how many people got received the CDK4/6 inhibitors. And again, the introduction of inclusion of the patients is again based on diabetes. People who are having uncontrolled diabetes or who are having a HbA1c more than 8 are excluded from the study. The randomization had happened with a fulvestrant versus capivasertib versus plus fulvestrant. So what is the dose of capivasertib? It is 400 mg twice day, 4 days on and 3 days off. Fulvestrant, as usual, it's a 500 mg day 1, day 14 and followed by 4 weekly once. And stratification based on liver metastasis, prior CDK4/6 inhibitors and region compared with the fulvestrant. So the primary endpoint, the dual primary endpoint is PFS by overall PFS as well as AKT pathway altered tumors. So here if you see overall, people who are having PA3K, unlike alpelisib, people are included here. So without or with AKT pathway inhibition, the people are got included. So how the analysis was done, the AKT pathway mutation analysis was done is based on the foundation medicine test, the CDX test was done. Based on that, they stratified it. It's not based on the liquid biopsy. Most of the people who got included is a FFP-based tumor sample where the foundation medicine CDX assay was done. The key secondary endpoints are overall survival, overall as well as AKT pathway altered tumors. Those stratifications are there. And objective response rate, again based on the 2 stratifying factors. The prior treatment, if you see here, the overall population and AKT pathway altered population, 69% of the people received CDK4/6 inhibitors. The inclusion, when it was started, it's only 51% are supposed to be there, but almost 70% people received CDK4/6 inhibitors in this setting. So here, the sequencing are post CDK4/6 inhibitors most of the times. It's not without CDK4/6 inhibitors. If not CDK4/6 inhibitors, we would think like based on other trials, it's okay to introduce CDK4/6 inhibitors in this setting. But here in the second line, most of the people already received CDK4/6 inhibitors and also most of the people received chemotherapy as well. And most of the people received 1 line of endocrine therapy prior. So again, it's always overall population versus AKT pathway altered population is the comparison. If you see here, the exploratory analysis, investigator assessed PFS in non-altered population, that including unknown. There is a good benefit is there, 7.2 months versus 3.7 months with hazard ratio 0.70. And again, in the AKT pathway altered population, and even little more benefit is there, that 7.3 months versus 3.1 months. It shows that whether it got altered or unaltered, there is a benefit is there, but it's more pronounced in the AKT pathway altered population with hazard ratio 0.50. So, be it liver metastasis, prior use of CDK4/6 inhibitors, there is significant benefit in all the subgroups. And we all know liver metastasis significance in HR positive or even at any breast cancer setting. So, people who are having a significant burden of disease also got a good benefit with the introduction of capivasertib irrespective of the AKT mutation. So, this is the overall survival again. Overall survival also there is significant, be it overall population or AKT pathway altered tumors, there is a benefit by adding capivasertib. The hazard ratio is 0.69 and 0.74. And overall survival at 28% maturity, the same slides which are replicating SABS 2022 and got presented even the NEJM as well, but the OS is set to mature. As per the 28% maturity overall, there is a benefit of OS also there by introduction of capivasertib irrespective of the AKT mutation. So adverse events, if you see here, capivasertib, unlike alpelisib, it's not having a significant alterations of the glucose levels, but there is significant diarrhea. Almost 72% of patients got a diarrhea and nausea and rash. But there is not much alterations of the sugars or not much rash is there, but its significant diarrhea is there compared to alpelisib. So the adverse event profile was comparable again in AKT pathway versus non-altered population. Both are having a equal adverse events, but still these adverse events are like to be to be given significance. So what are the conclusions we do have? It's the author's conclusion. So capivasertib plus fulvestrant provides a statistically significant and clinically meaningful improvement in the PFS in overall as well as AKT pathway altered population. Benefit from capivasertib was consistent across clinically relevant subgroups, including patients previously treated with CDK4 inhibitors, patients with liver metastasis, or without AKT pathway alteration. Overall survival as per 28 maturity, I like mentioned, there is a benefit is there, but it is yet to mature. So capivasertib plus fulvestrant safety profile appears consistent with that previously reported with a relatively low discontinuation rate due to adverse events. So henceforth, capivasertib plus fulvestrant has the potential to be a future treatment option for patients with HR positive advanced breast cancer who have progressed on an endocrine based therapy. So my discussion was SOLAR 1 trial, BOLERO 2 trial, the alpelisib and everolimus, the same sequence what we used before. Those are known to be effective agents. But most of us do face a problem regarding the tolerance issue. The tolerance and toxicity issues with the above agents is a big clinical hurdle to all of us. So capivasertib got an FDA approval with a better toxicity profile pertaining to hyperglycemia but with significant diarrhea. So all of us had to experience the tolerance profile in the real world setting. TMH got a trial with the capivasertib, like we all of us had to know the real world evidence of capivasertib here, and OS data is yet to mature, but still it's a very interesting drug and it's a very good drug to be sequenced further post progression of CDK4 inhibitors. So next is imlunestrant. My next abstract is regarding a SERD. So elacestrant is a one which was talked about in SABS 2021, and now it's a imlunestrant era with or without everolimus alpelisib in ER positive HER2 negative advanced breast cancer. What are the results from phase 1A, 1B EMBER study? It's a very interesting study. One is a dose expansion and one is a dose escalation cohort and other is a dose expansion cohort. I'll get back to it. What's the background of imlunestrant? What is it? So it's a next generation oral brain penetrating SERD. So all of us know the SERDs are having a better brain penetrance compared to the other AAs or everything, but here it's having a better brain penetration designed to deliver continuous ER target inhibition including ESR1 mutant breast cancer just like elacestrant. It's a phase 1A, 1B EMBER study. Imlunestrant demonstrated favorable safety, pharmacokinetics and preliminary efficacy in ER positive advanced breast cancer when administered as a monotherapy or with abemaciclib, and the recommended phase 2 dose is 400 mg OD. So there are 5 step-ups got happened, and 400 mg was a drug designed to go forward the phase 2 study. And already imlunestrant is having a good benefit in the early breast cancer setting as well. So what is the data we are going to look forward as we are going to present the first clinical data of imlunestrant with everolimus or alpelisib along with updated imlunestrant monotherapy data from EMBER study. So I discussed before, the phase 1 is a dose escalation study and phase 1B is an expansion study. So the sequence in the 5 cohorts are then the phase 1A study. The recommended phase 2 dose they selected was 400 mg with or without beta monotherapy or with a combination it's a 400 mg OD. So the phase 1 is a dose expansion. It's a 40 patients got included. There are 3 arms are there, imlunestrant monotherapy arm with everolimus 10 mg OD and with alpelisib 300 mg OD. The study design here, the primary objective already I discussed. First is to know the recommended phase 2 dose. The secondary objective is to assess the safety, pharmacokinetics and anti-tumor activity. The key inclusion criteria is endocrine sensitive or untreated de novo advanced breast cancer patients got included. are less than 3 prior therapies for advanced breast cancer in phase 1A and less than 2 in phase 1B. And PAK3AC mutation analysis required for alpha cohort is locally determined. So imlunestrant was administered orally OD or with the combination I mentioned before, and in 28-day cycles. So the 3+3 design, 5 levels I already mentioned, the physician choice enrollment is there with the everolimus or alpelisib. The clinical benefit ratio, PFS, objective response rate, I am not going to mention, all of us know very well aware of it, and safety data by CTCAE. Biomarker analysis as serial plasma levels were updated by PK ctDNA. It's more like we'll compare the cohorts of monotherapy, everolimus, alpelisib. So if you see the patient baseline characteristics, patients are having a significant visceral metastasis. As well as CDK4 inhibitors, there are significant people received the CDK4 inhibitors prior.
Dr. Kripa, Dr. Stephen is online, so can you please come to the conclusion slide?
Yes. So here if you see the imlunestrant plus everolimus has shown to be a significant benefit compared to alpelisib, and monotherapy also shown to have a good benefit, and the tumor response rates are very promising. The safety profile, if you see, it's comparable to Bolero as well as Solar trial. Be it the addition of imlunestrant to everolimus or alpelisib did not make much difference. The toxicity profile is almost same like Bolero 2 and Solar 1. But if you see the everolimus data is like promising compared to alpelisib data. The intolerance issues are the PFS, if you see it is better with the imlunestrant plus everolimus. So the conclusion is imlunestrant in combination with everolimus or alpelisib demonstrated robust efficacy in CDK4 inhibitor pre-treated hormone receptor positive breast cancer, and toxicities were comparable. It's almost comparable to all other trials. And once again, I thank the organizers, and also all of us are waiting for the roast by my boss, Dr. Senthil. Thanks for the opportunity again.
Thank you.